Welcome back. Now we're going to talk about acid-base balance and later on diuretic therapy. Exciting things. So to this point in 107, you have been introduced to acid-base balance in both the GI and respiratory modules. We're going to take just a much more in-depth look into it now. We discussed metabolic and respiratory acidosis and alkalosis in those modules. So one of the functions of the GU system is to help regulate these imbalances. It is slower but more powerful than other acid-base regulating systems. Okay, I'm going to start straight off with the video for you. This woman's voice kind of gets on your nerves. I think it's just like a recorded voice. But anyways, stick with it. It's got a lot of good information, and I'll see you in a few minutes.
pH is an indicator of acidity. The body's blood pH is strictly regulated within a narrow range between 7.35 and 7.45. This is because even a minor change in acidity may have devastating effects on protein stability and biochemical processes. Normal cellular metabolism constantly produces and excretes carbon dioxide into the blood. Carbon dioxide combines with water to make carbonic acid, which dissociates into hydrogen ions and bicarbonate. This is an equilibrium, meaning all of the components of the left and right sides coexist at all times, and the concentration of any component is determined by that of others at any given moment. The rule of thumb is, an increase in concentration of any component on one side will shift the equation to the other side, leading to increased concentrations of all components on that side, and vice versa. This equilibrium is central to understand acid-base regulation. Continued carbon dioxide production by all cells of the body drives the equilibrium to the right to generate more hydrogen ions. Because pH is basically a function of hydrogen ion concentration, more hydrogen means higher acidity and lower pH. Normal metabolism therefore constantly makes the blood more acidic. The body must react to keep the blood pH within the normal limits. This is achieved by two mechanisms. Elimination of carbon dioxide through exhalation. The amount of carbon dioxide exhaled by the lungs is regulated in response to changes in acidity. A decrease in pH is sensed by central or arterial chemoreceptors and leads to deeper, faster breathing. More carbon dioxide is exhaled, less hydrogen is made, blood acidity decreases, and blood pH returns to normal. Pulmonary regulation is fast, usually effective within minutes to hours. Excretion of hydrogen ions and reabsorption of bicarbonate through the kidneys. The kidneys control blood pH by adjusting the amount of excreted acids and reabsorbed bicarbonate. Renal regulation is slower. It usually takes days to respond to pH disturbances. Although all of the plasma bicarbonate is filtered in the glomerulus during the first step of urine formation, virtually all of it is reabsorbed back into the blood. Most of this reabsorption happens in the proximal tubule. The amount of reabsorbed bicarbonate in the proximal tubule is regulated via a number of mechanisms in response to changes in blood pH. It increases during acid loads and decreases during alkali loads. While the proximal tubule basically returns filtered bicarbonate back to the blood, the downstream collecting duct generates new bicarbonate by actively secreting acids. As protons are depleted from the distal tubular cells, the equation shifts to the right, producing more bicarbonate, which then exits into the blood. Hydrogen ions secreted into the lumen combine with urinary buffers, mainly filtered phosphate and ammonia, to be excreted in urine. The ammonia buffering system is particularly important because unlike phosphate, which is filtered in fixed amounts from the plasma and can be depleted during high acid loads, ammonia production is regulated in response to changes in acidity, and its concentration may increase several-fold when necessary. Blood pH is the main regulator of acid excretion, but potassium, chloride concentrations, and several hormones also play important roles. Pathologic changes may cause acid-base disturbances. Acidosis refers to a process that causes increased acidity, while alkalosis refers to one that causes increased alkalinity. It's not uncommon for a patient to have several processes going on at once, some of them in opposite directions. The resulting plasma pH may be normal, too acidic, called acidemia, or too basic, called alkalemia. Acidosis may result from inadequate function of the lungs, which causes arterial carbon dioxide to accumulate. This is respiratory acidosis. On the other hand, metabolic acidosis may result from excessive production of metabolic acids, ingestion of acids, decreased ability of the kidneys to excrete acids, or loss of alkali. Metabolic acidosis is characterized by primary decrease in plasma bicarbonate. Alkalosis can also be either respiratory or metabolic. Respiratory alkalosis is caused by increased ventilation, resulting in excessive exhalation of carbon dioxide. Metabolic alkalosis can result from excess loss of acids through the kidneys or gastrointestinal tract, bicarbonate retention, or ingestion of alkali. Metabolic alkalosis is characterized by primary increase in plasma bicarbonate. Thank you for watching. Please feel free to suggest a topic you want us to cover by leaving a comment.
Clear as mud, right? Acid-base balance. What I want you to understand from this is that the body's balance between acidity and alkalinity is called the acid-base balance. It is precisely controlled by the body because even a minor deviation in acid-base balance can severely affect many organs. Mechanisms to control acid-base balance can be divided into three. We have the lungs, the kidneys, and the buffer systems. So the role of the lungs is going to be to control blood pH through the release of carbon dioxide through breathing. Carbon dioxide is normally mildly acidic. It's a waste product of processing or metabolizing oxygen and nutrients. So it's constantly being produced by cells. It then passes from cells into the blood. The blood carries carbon dioxide to the lungs where it is exhaled. As carbon dioxide accumulates in the blood, the pH of the blood decreases, meaning the acidity increases. The brain regulates the amount of carbon dioxide that is exhaled by controlling the speed and the depth of breathing. The amount of carbon dioxide exhaled, and consequently, the pH of the blood increases as breathing becomes faster and deeper. So by adjusting the speed and depth of breathing, the brain and lungs are able to regulate the blood pH minute by minute. So it's very fast, which they just talked about in that video, and I'll say a couple more times, I think. As far as the kidneys are able to affect blood pH by excreting excess acids or bases. The kidneys do have some ability to alter the amount of acid or base that is excreted, but because the kidneys make these adjustments more slowly than the lungs do, this compensation generally takes several days. So the kidneys work, I think, stronger but slower. And then we have the buffer systems. These are another mechanism for controlling blood pH and involve the use of chemical buffering. This helps guard against sudden shifts in acidity and alkalinity. The pH buffer systems are combinations of the body's own naturally occurring relatively weak acids and weak bases. These weak acids and bases exist in pairs that are in balance under normal pH conditions. The buffer systems work chemically in order to minimize changes in the pH of a solution by adjusting the proportion of acid and base. The most important pH buffer system that I want you guys to know about is going to involve carbonic acid, which is a weak acid that is formed from carbon dioxide dissolved in the blood, and bicarbonate ions, which are their corresponding weak base. So now we're going to talk about pH of the blood. So I know this we've talked about, pH of urine. So switch gears, we are now talking about blood, okay? So an important property of blood is its degree of alkalinity or acidity. The acidity or alkalinity of any solution, including blood, is indicated by the pH scale. The pH scale ranges from 0, which is strongly acidic, to 14, which is strongly basic or alkaline. A pH of 7 in the middle of the scale is neutral. Blood is normally slightly basic, with a normal pH range of about 7.35 to 7.45. Usually the body maintains the pH of blood close to 7.4, 7.40. So we have a little bit of a range on either side, 7.35 to 7.45. Usually it's going to be pretty spot on at 7.40. So blood acidity will increase when the level of acidic compounds in the body rises. This can be through increased intake or production or decreased elimination. Or the level of basic or alkaline compounds in the body falls. This can be through decreased intake or production or increased elimination. The blood alkalinity increases when the level of acid in the body decreases or when the level of bases increase. Another part of blood that I want you to be aware of is bicarbonate. We call it HCO3. I call it bicarb because I can't say HCO3 faster than I can say bicarb. So bicarb is a byproduct of metabolism. The blood brings bicarb to the lungs where it is exhaled as carbon dioxide. The kidneys also help regulate this through excretion and reabsorption, and this ultimately regulates the pH. So the normal range of bicarb that we will be seeing within blood is going to be 22 to 28 MEQs, and that is, these numbers will make a little bit more sense once we get a little farther down the road here. I can get my screen to advance. There we go. The last numbers I want you to be aware of are the PCO2. This is the partial pressure of carbon dioxide. So this is the measurement of carbon dioxide within arterial or venous blood. Generally, it will serve as a marker of sufficient alveolar ventilation within the lungs. And under normal physiologic conditions, the value of PCO2 is going to be between 35 to 45 millimeters of mercury. So what the heck does this mean? Basically, what I'm trying to get down to are the differences between acidosis, alkalosis, and the metabolic and respiratory components of them. So again, you might have covered respiratory acidosis and alkalosis with Deb. We briefly covered metabolic acidosis and alkalosis in GI. So this is going to be a little bit of a review, hopefully. So respiratory acidosis, what you'll be looking for as far as lab values, you will see it done on either a VBG, which is a venous blood gas, or an ABG, which is an arterial blood gas. You'll be looking for those three values that we just went over. So pH, PCO2, and bicarb. So in somebody with respiratory acidosis, you would probably see a pH less than 7.35. So again, that means that their blood is acidic. You will probably see them with a high PCO2 and a normal bicarb level. So some causes of respiratory acidosis are going to be really kind of anything that perpetuates hypoventilation or respiratory obstruction. So this might be anesthesia, overdose, again, anything that's going to cause someone to breathe slower or not very deep, or respiratory obstruction. So someone experiencing a pulmonary embolism, potentially some pneumonia, COPD, pulmonary edema. Big symptoms of respiratory acidosis are going to be difficulty breathing, increased respiratory rate, disorientation, drowsiness, headache. So again, this is kind of a neat little, I got 4 of these for you. Nice little picture for those of you who need pictures of things. This is a picture of respiratory acidosis. So again, over here we have some causes, and then some signs and symptoms, things like that, okay? So again, here are pictures of your lungs, retention of CO2 by the lungs. That's really what we're talking about when we're talking about hypoventilation. This person is not expelling enough CO2 when they are breathing because they're not breathing very well. So that CO2 gets kind of stuck in the lungs, it gets stuck in the blood, and then they are in respiratory acidosis. Next, we have respiratory alkalosis. So here, we would also have a pH level that is high. So their blood is going to be basic or have high alkalinity. So it's going to be greater than 7.45. Their PCO2 is going to be low, so it will be less than 35. And they are still going to have a normal bicarb level. So normal, again, is 22 to 28 MEQs. Some causes of respiratory alkalosis are going to be hyperventilation. So this can be caused by anxiety, fear, pain, hypoxia, fever, anything that's going to cause that person to breathe a lot. So either very rapid breathing, and sometimes even in mechanical ventilation, if we are over ventilating somebody, we can put them into respiratory alkalosis. So if you guys are ever seeing anybody who is on a ventilator, you will see that they will be checking their blood gas levels fairly frequently in order to make sure that we are not over ventilating them. Some symptoms are going to be lightheadedness, confusion, syncope, paresthesia, so that's like that numbness or tingling, muscle cramps, and they're usually going to be taking deep, rapid breaths. So that will be also an important sign or symptom. Again, here's another nice picture for you if we're looking at the lungs here. So we are losing too much CO2 from the lungs. So that person is breathing off, we call it blowing off CO2. Their body is trying to get rid of it. Let's see. So some other signs and symptoms, these are the ones I really want you to focus on, but just be aware that there are a lot of things related to respiratory alkalosis. And then next we have metabolic acidosis. So metabolic acidosis will be diagnosed because the person will have a low pH, right? So acidosis, their pH is going to be low. It's going to be less than 7.35. They're going to have probably a normal PCO2. So normal is between 35 to 55. And they're going to have a low bicarb level. So low meaning less than 22 MEQs. Some causes of metabolic acidosis are going to be diarrhea, fasting, potentially DKA, sometimes renal disease or forms of shock. Symptoms will be a decreased blood pressure, potentially some twitching, warm flushed skin, drowsiness, and those Kussmaul respirations. So again, we have our nice picture. So metabolic acidosis is related to the decreased ability of the kidney to excrete acid, conserve bases. So we might see that, and again, of course, if somebody is having severe diarrhea and they are getting rid of their acid, or sorry, they're getting rid of their bicarb, that's going to increase their acidity in their blood. So that's why something like diarrhea could absolutely put someone into metabolic acidosis. So it's, always a good idea when you're seeing someone with diarrhea to make sure it's hopefully just a minor case, but if it's prolonged, we really got to start worrying about more systemic issues. But yeah, that's beyond us in GU. We're talking about GI stuff was last test. Now we're talking about GU stuff. So lastly, we're going to talk briefly about metabolic alkalosis. Metabolic alkalosis will be presenting with a high blood pH, so greater than 7.45. This person will probably have a normal PCO2 and a high bicarb level. So a high bicarb level would be probably greater than 28. Some causes of this might be vomiting, excessive antacid intake, potentially NG tubes or diuretics, depending on the diuretic. So you're probably thinking, why does an NG tube or vomiting? So again, the stomach acid is acidic. So if we are suctioning all of that out with an NG tube, where this person is vomiting a lot, we are effectively removing acid from their body. So now their blood is going to become more basic. Some symptoms will include confusion, dizziness, irritability, tremors, muscle cramps, and reduced respiratory rate. So we go to our picture here, we've got our causes over here. So again, a decrease in acid or an increase in base will cause metabolic alkalosis. And those are your nice little kidneys over there. So restlessness followed by lethargy, compensatory hypoventilation, that's what we talk about when we talk about decreased respiratory rate. So that person is trying to, their brain is taking over and slowing down their breathing in an effort to fix their levels, essentially. So all of these systems work really well together in order to try and keep acid-base balanced, right? Because again, we go back to any deviation in a normal acid-base balance can be really, really detrimental to kind of the entire body eventually. So how do we know if something is metabolic versus respiratory? So if the increase or decrease in pH can be explained by an abnormal PCO2, then it is a respiratory issue. If the PCO2 is normal, then it is a metabolic issue. So an example of this is in respiratory alkalosis, you will see a low PCO2, whereas in metabolic alkalosis, you will see a normal PCO2. So always be looking at that when you're, at least when you're looking at blood gas values. Compensation is also something I wanted you to be aware of. Really, I just want you to know that compensation does happen. Acid-base imbalances may be either compensated or uncompensated. So in a compensated acid-base imbalance, so we might say something like a compensated metabolic acidosis, the body is trying to restore a normal state by altering that buffer system that is not involved in the original problem. So the body is trying to pull all of its resources in and trying to compensate for this. That's all I really need you to know about compensation, just that the body does work very, very hard to get acid-base balance back to normal. And just when you think you can't get enough, lastly, we're going to talk about diuretic therapies. And again, we're going to talk about prototype drugs, so you're only going to see 1 or 2 drugs for each type. Hopefully that, again, reduces the burden of medications that you feel you need to memorize. So a diuretic is any drug which promotes the formation and excretion of urine. There are many ways of accomplishing this, but the end result is always going to be that they remove sodium and water from the body. Primary usage is generally actually not for renal system problems. Usually it's going to be for another system. So probably you probably remember talking about certain diuretics with Krista when you were talking about the heart. So we will usually see diuretics used for congestive heart failure, hypertension. We might also see them used for edemas associated with cirrhosis, some cerebral edema, and even glaucoma. The first one we're going to talk about is going to be your loop diuretic. So we're going to talk about Lasix. Hopefully that is a familiar term to most of you at this point. So this is going to be your prototype drug. So look this one up and understand what it does. So Lasix works in the loop of Henle. So if you don't know what that is, pop back into the A&P recording. There is a good video on it. That's the urinary video 1, I think, that is embedded in the PowerPoint. It talks about all the different parts of the tubule. So furosemide works in the loop of Henle. It is a loop diuretic. It works in the ascending portion of that loop. It works to block chloride and sodium reabsorption, and it promotes potassium wasting. We will usually see this used for hypertension, congestive heart failure, and certain hepatic and renal diseases. As far as nursing considerations, Be aware of any electrolyte imbalances, especially hypokalemia. This is a potassium wasting diuretic, meaning along with sodium and water that it's forcing your body to eliminate, potassium is going with it. So people on Lasix are definitely at a risk for developing hypokalemia. Of course, with any diuretic, we worry about a fluid volume deficit. Also, there's the potential for risk for falls if they are getting dizzy, because now we are reducing their overall fluid volume. We want to be monitoring their I&O, their daily weights, keeping an eye on any edema that they have, looking at their heart rate and blood pressure, because of course now we know all the different ways that the kidneys regulate blood pressure, which of course blood pressure will ultimately help determine what your heart rate is. We're also going to want to trend and monitor labs, specifically probably BUN, creatinine, and electrolytes. And then we're going to work to replace potassium per orders. So always very important when you are giving Lasix to make sure you know what that person's potassium level is before you give it. Because if it's low, you don't want to be giving Lasix without also repleting their potassium levels, or they are definitely going to be hypokalemic. You're going to make it even worse, and it will be your fault as the nurse. Just because the doctor ordered it and pharmacy cleared it, you were the one who gave it. So make sure you know the normal levels of potassium and at what point you should be talking to the doctor about repleting it. Next, we have thiazide diuretics. So our prototype drug here is going to be hydrochlorothiazide. You will see it abbreviated HCTZ. Hydrochlorothiazide works in the distal convoluted tubules, and it works to inhibit sodium and chloride resorption. We usually use this for hypertension and CHF. It is weaker than many of the loop diuretics, but people are still going to be at risk for electrolyte imbalance, again, hypokalemia, fluid volume deficit, risk for falls. So as a nurse, we're going to want to monitor I&O, daily weights, edema, vital signs. We're going to trend those labs and, of course, replace potassium and really any electrolyte as needed for this person. Potassium sparing diuretics. So we talked about furosemide is absolutely a potassium wasting diuretic. Aldactone, I can pronounce that one, is a potassium sparing diuretic. It works in the collecting tubules. It interferes with sodium and potassium exchange. It also works to bind with aldosterone receptors so that it blocks reabsorption of sodium and water. Sodium and water are, of course, then excreted, but potassium is spared. So big difference between something like aldactone and Lasix. It's going to be used for edema, hypertension. Will usually be used in conjunction with a potassium wasting diuretic. So don't be too alarmed if you see something like aldactone and Lasix used together. It is normal because something like this, when used with Lasix, will help sort of mitigate the amount of potassium that is lost. Nursing considerations. Potassium-sparing diuretics are weaker, just like the thiazide diuretics, than loop diuretics. They do have the same potential for adverse effects, but they are less likely. So again, electrolyte imbalance. Important to note with potassium-sparing diuretics, this person might develop hyperkalemia because now we are getting rid of all of their fluid, but hanging on to their potassium. So normally we do lose a fair amount of potassium with urine. So if we're just getting rid of water and sodium, this person might be at risk for developing hyperkalemia. They're also going to be at risk for a fluid volume deficit, and then everything else we've talked about. Risk for falls, we're going to monitor their I&O, daily weight, edema, vital signs, and we're going to trend their labs. Mannitol is an osmotic diuretic, so it's going to be your prototype drug. For my purposes, I don't need you to know a lot about it. It's going to be more important for Krista's purposes in neuro stuff. So for me, I just want you to know it is a diuretic. It's an osmotic diuretic. It works in the proximal tubule in the descending loop of Henle. It works to produce an osmotic effect, which increases the osmotic pressure of filtrate, which decreases reabsorption of water and leads to diuresis. This ultimately pulls fluid into blood vessels and nephrons from the surrounding tissues, leading to increased urine production. Used mainly to decrease intracranial pressure and cerebral edema from head trauma, and to help prevent kidney damage and acute renal failure. I've personally seen it used for acute kidney failure once, so again, it's not so much for me. I just want you to be aware that it is a diuretic. It does have significant adverse effects, so that's something you should be aware of as the nurse, including convulsions, thrombophlebitis, pulmonary congestion, and of course with any diuretic we worry about electrolyte imbalance, fluid volume deficit, risk for falls. This person's going to need to be on a strict INO. Potentially they might have a Foley catheter because they really need to be keeping track of almost every single milliliter that comes out of that person. Daily weight, edema, vital signs, and lab values will also be important to keep an eye on. Finally, we have the CAIs. These are the carbonic anhydrase inhibitors. Our prototype drug is Diamox, because I cannot pronounce that first one, I'm sorry. This works in the proximal tubules. It works to block the action of carbonic anhydrase, which is normally there to promote reabsorption of bicarb, so this increases excretion of sodium in water. Very limited effect, not generally used so much as a diuretic, it just happens to be a diuretic. It's usually going to be used to lower the intraocular pressure that is present in many glaucomas. Nursing considerations, electrolyte imbalance is possible, especially hypokalemia, which will be most likely in very early therapy. Usually once someone has been on something like this for a while, they're not too much at risk for developing hypokalemia. But once they're starting, their labs should be checked fairly frequently. Metabolic acidosis is a possibility. We're going to monitor their INO, their weight, their vital signs, and trend their labs. Last thing I wanted to talk to you about was patient teaching for diuretic use. So a lot of times you'll see people on diuretics. They don't always necessarily know why they're on it, what it does. Most people will call them like their water pills. And it seems counterintuitive, but it is actually really, really important to maintain good hydration. Unless they're on a fluid restriction, usually drinking that water will help kind of perpetuate the effects of diuretic use. So it is good to make sure that they are maintaining good hydration. If they're not drinking enough and they are taking diuretics, they can become dehydrated. And then mind their potassium. We should be encouraging anyone who's on a potassium wasting diuretic like Lasix, furosemide. They should be eating potassium-rich foods. These include bananas, oranges, dates, raisins, potatoes, meats, and fish. If someone is on a potassium-sparing diuretic, of course they should be avoiding too much extra potassium. One thing that many people don't usually know is that many salt substitutes can actually be very high in potassium. So it is important, people think they have CHF, they're on one of these potassium-sparing diuretics, they should be avoiding salt, which is true, so they start using one of those salt substitutes, but it's got a lot of potassium in it, and then their potassium's through the roof. And they can't figure out why, and it's always because of that Mrs. Dash or whatever their salt substitute is. We should also make sure that we're telling our patients to change position slowly and to get up slowly. Of course, we are worried about dizziness and syncope related to any orthostatic hypotension. Of course, making sure that they're following up with their healthcare provider regularly for lab work. Going to be really important to make sure that their kidneys are working well and are doing okay with this diuretic use. We're putting a lot more strain on those kidneys. So make sure that their kidney function is holding up and be checking on their electrolytes as well. Of course, keeping track of daily weight, seeking medical care for any vomiting or diarrhea, because things like vomiting and diarrhea can super increase their risk for electrolyte imbalances, and then monitoring for signs of hypokalemia or hyperkalemia. For hypokalemia, those signs are going to be muscle weakness, constipation, irregular pulse, lethargy, all that fun stuff. Hopefully you all remember everything there is to know about hypokalemia from my lecture on hypokalemia. And that's it. You stuck with me. Thank you very much. This was the last recording. So if you're here, you can go finish the pre-work for the class, and then you're all set. And I will see you on Monday and Thursday, depending on when you're watching this. Thank you.